This is a roundtable discussion on advances in radial intervention. We're in Barcelona and this is day 3 of CIRSE 2019. For the next hour or so, we're going to discuss advances in the transradial space. And for those of you who are familiar with the radial space, there have been significant advances, particularly in interventional radiology in the last few years. I have with me Dr. Damien Mullen from the Christie in Manchester, Dr. Roger Barranco, who works here as both a body and neurointerventional radiologist, and Yahya El-Hagar, who works at the Liverpool in Sydney. Each of the people here today have significant experience in the transradial space and have really advanced the practice. And we're going to start with a very important topic, and a topic that is very new to everyone practicing in the radial space, both interventional radiology, interventional cardiology, and of course, interventional neuroradiology. And that is working from the anatomical snuffbox or distal radial intervention. And Damien, just to get your opinion, where did you start, or how did you start your practice in terms of moving from conventional to distal radial access?
Yeah, so we've been practicing radial access for, I guess, nearly 3 years now. And moving from femoral access to radial access was a game changer for us. And I thought that distal radial will be an evolution, but I think there is still an element of revolution there. It has changed our practice, it's changed our workflow. And now our default position is that we will perform distal radial access. Some of that is due to the patient subset that we see. We see a lot of, we're an oncology centre, so we are purely oncology. And oncology patients are prothrombotic. You know, they're going to get occlusions, they're going to get clots. And we had a kind of a 5% occlusion rate for our conventional radial for patients that were having a repeated procedure, so more than one procedure within a month. And if you occlude your conventional radial, then you don't have any options. You can go a bit higher, but then you're running into the risk of causing hematoma and getting a spasm and things. So we've moved to distal radial because it gives us a little bit of wriggle room. There's a luxury because the worst case scenario, if you do occlude the distal radial, if you're bringing that patient back 1 week later for a repeat TACE or a repeat Y90, you can just go 3-4 centimeters higher and do the procedure. So that was based purely on operator experience, but I think distal radial has a huge benefit for patient experience as well. We find that it can be slightly uncomfortable for a patient to fully extend their arm out and to keep their arm in full supination for 2-3 hours, and you tend to find that the arm will creep around and then you're moving it back, and the arm creeps around and you move it back. It's a much more comfortable experience for the patient to have a distal radial puncture because it's a very kind of anatomical neutral position, and it makes it a very easy procedure. So that's patient experience during the procedure. There's also an element of patient experience post-procedure where, again, it's more comfortable for the patients not to have an occlusive band around, and they can move the wrist. They don't have to worry about staying, like the mantra ephemeral, you must lie still for 4 hours.
Yeah.
And with radial, we were saying, you must keep your wrist still for 25 minutes. But now, if you go distal, they can move around. So there's that patient experience and the operator experience. But tertiary to that is actually, it can make it easier for a centre who hasn't done radial to convert to radial by saying you can go distal, because I found the biggest challenge for me for conventional was you're on the wrong side of the table. Your brain doesn't cope particularly well with being on the wrong side of the patient, on the wrong side of the table, working right-handed if you're a left-hander, or working left-hander if you're right-handed. So distal radial gives you an opportunity to actually work as you might do normally, especially if your room is set up to do a femoral approach. You can bring the arm over and approach from a very anatomically comfortable position. And that's not possible with conventional radial because it's impossible to get your arm across. So it really is a revolution of an evolving evidence-based technique of conventional radial, and distal radial gives you that opportunity to make it a better patient experience and make it a better operator experience. So I think it really has changed our practice, and I thought that the change of practice for conventional would be the end, and I think distal radial is just taken it a step further.
Yeah, I mean, I agree. I think when it comes to distal intervention, there's so many advantages to the procedure itself. And the same with me, I found moving from conventional to distal to be pretty significant, even though we were a pretty advanced radial central already. But like you're saying, I think it's really important for a lot of operators who are starting out, moving from femoral to radial. Sometimes it's easier just to go straight to distal rather than have to try and deal with the room setup and the change in the room setup. Did you find it challenging at all in terms of access? Any issues that you found along the way? Tips and tricks potentially for people starting out?
Yeah, so we now train centres to perform radial access, and we get people coming through. And I guess like anything, it's patient selection. Patient selection is key. You want to choose a good patient for your first 5-10 cases. Traditionally, I had said, you choose a nice case, go conventional radial, and I'm now moving forward to saying, well, actually, it might be beneficial to you to go distal. That's with the proviso that I do think distal is technically slightly more challenging. I think that's due to anatomy and due to operator experience. The anatomy and the rationale are intimately intertwined when you're performing a distal radial puncture. It's more superficial. You've got the comfort of a good landing zone on the wrist where you've got a few millimeters of soft tissue before you can actually get the needle in. When you go distal, there's less tissue, so it's quite it's an almost immediate puncture. So with an immediate puncture, you don't visualize the needle going in quite as nicely, so there's the opportunity then to hit something else or to go subintimal. So I think it is a slightly more technically challenging puncture. It's important to get your orientation correct, to make sure that the artery doesn't run just straight as it does conventionally. There's a little bend, and if you're slightly off with your puncture, then you may find that it's subintimal. You then cause spasm, you cause dissection, you cause hematoma. And I think a luxury is that if you do that, you can still move and do conventional in 2 minutes' time. So it's a more difficult puncture. We tend to give anesthetic with a mix of GTN and lidocaine, not just to cause vasodilatation, but actually also to increase that landing zone so you can then visualize the needle going in. So it's important to actually create space to visualize your needle, but also to recognize that it's not a straight puncture. You do have to angle your needle slightly obliquely to get it over and around the wrist. If you don't, you can go into side branches, into your scaphoid branches, into all the osseous branches that you never knew existed when you were a medical student.
Yeah.
So I think there's a learning curve for distal. You have to be a little bit more cognizant of the slight variation in anatomy, and you have to be a little bit more particular in your puncture. But we should be particular on a puncture wherever we are, be it distal radial, radial or femoral. We should be performing the best technique possible. So it's a very slightly more difficult puncture than a conventional radial, but confers significant advantages.
Yeah, I mean, it's interesting that you bring up the point about having to have your needle slightly obliquely and not straight, because when I teach people to do this, I think the most common mistake is that people don't think about where the artery is actually going. And so when they're puncturing, they puncture, they often will hit the side wall of the vessel with the needle, and then the wire doesn't track, but they're getting blood back, and they can't understand why. And it's purely based on just a slight change in angulation or direction of the needle to get it to actually go down the artery. So there are little nuances, I think, and as you learn and you do more and more of them, you pick up these nuances and these subtleties in terms of what you need to do. In terms of hemostasis in the distal space compared to conventional radial, did you change your protocol in any way to adapt to it, or have you left everything exactly the same?
So we've changed, and I think that the benefit of a distal radial puncture is that the artery is quite superficial. There are some disadvantages of that, which we'll maybe get onto in a second, but with our conventional radial, there are a variety of bands available to achieve hemostasis. We use a balloon occlusion device, and you inject 7 mils. We've brought that back to your base is 5 mils, and you'll then try and sequentially get it down over the course of a period of time. And that was about a 20-minute protocol.
Yeah.
With distal radial, we use a variation of that balloon device, and our base position is about 4 mils, and you then get it down to 3 mils, and each subsequent mil or half mil you're taking out, it reduces that step. So our hemostasis is now reduced to between 10 and 15 minutes, which seems insignificant, but that's a massive impact upon nursing time. On aftercare, it gives you confidence that you don't have to worry about, is this patient going to bleed? It is a very controlled hemostasis due to the superficial nature, so it does have a big impact on our practice. You're not having to worry about a patient bleeding out or having any significant hematoma issues.
Yeah, I mean, and again, it's pretty much exactly what I experienced as well. We had a really fast hemostasis protocol with conventional access, 25 minutes, and then when we moved into the Snuffbox, it came down to 10 minutes, and it sounds insignificant, but that 10 minutes is essentially the time that it takes to get a patient from the angio table onto their bed, and then you've completely deflated. And so I think in a lot of centers where potentially not being able to nurse patients in radiology and having to send patients straight back to the ward, being able to do that without a band inflated is huge, because then you'd have to train a significant number of nurses. And like you say, I think one of the things we forget about in what we do every day is the impact that our procedures have on nurses and how much time nurses have to spend with patients after a procedure, looking after them. And I know for sure, moving from femoral to radial and then to the distal space, we definitely found a significant decrease in the amount of nursing time. And so our nurses embraced it, but I think it's really key if you're starting out in your practice that is a focus as well. I don't know if you would agree.
Oh, absolutely. It was a paradigm shift changing from femoral to radial. Initially, our nurses were a bit skeptical, and I think we still have some skepticism amongst the AR community who are not embracing the radial approach. And that was aligned with our nursing body, our radiographer body, who thought, it's an extra 15 minutes before you get access, it's an extra 15 minutes at the end. But if you achieve a robust technique and you're running with it, it has massive advantages for aftercare, which aren't available for femoral access. And over the course of a year, then that adds into 6, 7, 8 extra days of IR theatre time, which is massive if you're doing 10, 12 cases a day.
So I'm going to ask each of you a controversial question, because I'm controversial in general. So, Damon, and be as honest as you can. And I'm going to pick one procedure for each of you so that we're not kind of generalizing in terms of what we're doing. But for you, I'm going to say oncology, because you're working in an oncology center. Do you think that radial should be the default for oncology procedures?
Absolutely, yeah. I think that there's no question. The procedures that we perform are potentially uncomfortable procedures. They're designed to kill tumors. Doing that will cause pain for the patients. And I think that's the key take home for our patients is we are performing procedures which will cause pain. We can control that pain with midazolam and fentanyl. But actually, once the patient leaves the room, we tend to forget about the patient to an extent, and it's then up to the ward doctors or the recovery doctors to control that pain. Our procedures cause pain. If you're telling a patient you must lie still for 4 hours because we need to protect your femoral artery, it's quite uncomfortable for a patient to have to lie still. If you drop a TV on your toe, your reaction is to jump up and down, walk around the room trying to walk that pain off. Exactly the same for a wide-angle procedure, for a TACE procedure where you're causing organ pain. If a patient can hop off a table, walk around, and deal with that pain, there's a massive patient benefit there, albeit maybe a psychological benefit. But if a patient can walk around, walk to the toilet, walk to, go outside, it's a huge benefit, and we're reducing our levels of the amount of post-procedure analgesia that patients need. So it's a huge thing for our patients, and I think this isn't just a new technique for the sake of a new technique. It's a patient benefit.
Oh yeah, and I think that kind of hits the nail on the head. It's, this is better for patients. Whichever angle you look at this from, whether you look at it from a potential bleeding risk, whether you look at it from a patient comfort point of view, ease of cannulation of vessels, whatever you want to look at, I think at the end of the day, for me, and that's why I do it as well, is because I think it's better for the patient. And I absolutely agree. I think this should be the default procedure for oncology. I see almost no reason ever to go from the groin if you don't have to. So just to end off, I know you did a really exciting procedure a few weeks ago, a chemo infusion through the radial artery. So just talk me through some of the challenges that you felt, because I mean, you really were pushing the boundaries in terms of what you can do, but I think that's exactly what we need. We need to be able to push ourselves to points where you otherwise wouldn't think of doing a procedure, for example, through the radial artery, more than anything to show people what you can do rather than, just the basics. So yeah, just if you don't mind, just talk us through exactly what you did.
So this was an hepatic chemosaturation, which is a relatively established technique where you isolate the liver and you then perfuse the liver with melphalan, which is a form of chemotherapy. It's evidence-based, proven for ocular melanoma metastases, and conventionally operators have gone from the groin. So we're now a radial practice. I haven't done a femoral puncture in about 2 years. I think I can still remember how to do it. I hope I can still remember how to do it. I need to remember how to do it because you have to have all of these tools in your armorium. It's essential to have options. But I'm now a radial first. So this was an hepatic chemosaturation for liver metastases. You have to isolate the liver, you have to hemofiltrate the blood, and to hemofiltrate requires a lot of heparin. So this patient had 50,000 units of heparin.
50,000?
50,000. Wow. And I think that's important because we have seen occlusion in our conventional radials, so we've upped our heparin from initially 2,000, then to 3,000, now to 4,000. And there's a fear amongst IRs of giving heparin for any IR procedure. Our standard now is 4,000 for a standard procedure, but 50,000 is a huge amount. We're confident that that's not an issue because the hemostasis from a distal radial is so easy to achieve that we don't worry about causing a significant hematoma. That's as long as you're cognizant of your anatomy. Your anatomy is crucial. Ultrasound puncture is crucial. You have to know exactly where to puncture the artery, and if you can puncture the artery above the web space, in between the tendons, you're not hitting nerves, you're not hitting your cephalic veins, you're not hitting anything that you shouldn't be hitting. It creates confidence, and if you have that confidence in a technique and you can achieve hemostasis easily, then it's 50,000 units of heparin is not an issue. And warfarin isn't an issue, aspirin isn't an issue, all of these antiplatelet medications aren't an issue if you go radial, and less so if you go distal radial.
So after this procedure, you're given your 50,000 units of heparin. If you had done this femorally, what would have been the sequence for you to get those catheters out? Because I'd be pretty scared pulling out a catheter and a sheath in a patient with 50,000 units on board, regardless.
Absolutely. So the conventional aftercare of these patients is that you walk away, the patient goes to intensive care, and about 3 hours later, you then come down to intensive care, you take a catheter out, and you're still pressing in the groin and then hoping that they don't bleed. You're in intensive care, so you don't have the option of putting in a fluoro-guided closure method, so it is a very hands-on thing. But going radially, it's 3-4 mils in a balloon, in the Snuffbox, and you can visualize hemostasis. That has some disadvantages because obviously the visualization of hemostasis has changed slightly in our practice from going distal radial to conventional radial because we now don't use the Barbeau for patent hemostasis. There's a slight offset there, but I think the offset is offset by the benefits that distal radial gives us.
So in that particular case, did you remove everything and get hemostasis in the room instead of sending the patient back to ICU with the catheter and sheath and everything in? So that's fantastic.
It's aftercare, it's nursing care. It's an immediate.
Yeah, that's fantastic. I mean, I think that in itself more than anything else highlights, I think, the benefit of Radial, these very complex, high-end cases where, you're not having to send patients back to the ward with angiographic equipment still in them, having to go back up there. It's your time up in ICU having to get hemostasis, and I would still be pretty wary about trying to get hemostasis, particularly in larger patients, once you're given 50,000 units.